So, going to talk to you about development of a high throughput methodology for doing subtype classification. I'll give you the background. These are my disclosures. The relevant one is we have a patent for the TCGA classifier. That's the subject of this work. So, just by way of background, we published this last month. 1011 was a randomized trial of extended versus standard pelvic lymphadenectomy at the time of radical cystectomy for patients with curable muscle invasive bladder cancer. The scheme is on the right. There was no difference in the primary endpoint of DFS in the top curve, secondary endpoint of OS in the bottom curve, establishing standard pelvic lymphadenectomy as the standard of care. So that's for the surgeons, external, internal, and obturator lymph nodes. So that's the patient population. From that, well, let me do this. I should go forward and then backwards. Oh, it skipped a slide. Okay. So we, as part of the TCGA, using unsupervised hierarchical clustering, described 5 molecular subtypes. I think unless you've been living under a rock, you're fairly familiar with those. And then in 2019, Jaegil Kim, who did the RNA-seq work and developed the classifier, developed a single patient classifier, so you can take the results of that unsupervised hierarchical clustering and apply it on an individual patient basis, because that is the only way that you can then get in to use it clinically, test it in clinical trials. The data on this slide simply shows fidelity to the subtype calls from the whole transcriptome profiling. So we were very interested now for a long time to develop a simple high throughput way of doing subtyping, I think for obvious reasons. And so I think most people in this audience are familiar with NanoString. This is the heat map of the first 48 samples that we ran. Fidelity, again, reproducibility, I should say, just with a binary stratification of basal versus luminal with a very high accuracy. And those are the advantages down below. I'll come back to that at the end. So this is a pie chart. I'll just describe these different numbers to you. So we had 48 patients that Teresa Copey, who's a co-investigator on the trial, had managed to get funding from Illumina to do RNA-seq. So that actually is sort of legacy data, but we had additional RNA from those first 48 samples. We obviously ran the single patient classifier on that RNA-seq and then developed this custom code set for NanoString and ran that, and that's the validation cohort. And I'll tell you that there's a pretty high fidelity between the subtype calls, and then fast forward, we got the RNA from the rest of the samples. Now, for those of you who've read the paper, we had 592 randomized patients. So what we're dealing with is a subset of patients where we had primary tumors from either TURBT or the radical cystectomy. And I will just tell you without showing you the data that it's not exactly representative of the entire cohort. So just keep that in mind. But that 278 is now we've run RNA-seq at Baylor on the rest of the samples, and we've ran the NanoString classifier on that as well. So I don't want you to read this, but these are expression signature scores that are derived from the NanoString data. And what I can tell you, it looks very similar to what we described and it wrote in the Cell paper from the TCGA, and kind of what you would expect. Signatures up and down by various subtypes, and fairly predictable, and again, I think reproducible. Just another sort of element suggesting that we were on the right track with this NanoString classifier. So the rest of these data are NanoString subtype calls. If you look at the top, for those of you who are students of this, you'll see that the distribution of the 5 subtypes is pretty similar to what we described in the TCGA. Keep in mind that the TCGA was you couldn't have any prior chemotherapy. You could have intravesical BCG for those patients that had progressed to a muscle invasive bladder cancer. And then a smaller population are evaluable for pathologic response in the cystectomy specimens. So in the bottom table are all the pre-specified stratification factors and then the subtypes, and you'll notice that none of them are statistically significant, at least for the outcome of DFS. So these are the overall survival curves stratified by the 5 subtypes. I can tell you that these are not statistically significant differences looking at them overall, although kind of what you would expect, luminal papillary has a bit better prognosis than basal squamous and neuronal. Same story for disease-free survival. And so this is a slightly different type of analysis where we've collapsed the subtypes into 3 categories. If you're a student of this and interested in it, we published this in Clinical Cancer Research in January using SWOG 1314, which was the Coxon trial. And there's some practical reasons of why we did that analysis. But again, no statistically significant difference for the pre-specified endpoints. Now, the rest of this, I'm going to just go through very quickly. So this is pathologic CR rate, and you see similar rates between basal squamous and luminal papillary. And this is with and without neoadjuvant chemotherapy. And then pathologic downstaging was a composite endpoint of path CR, and then anything less than PT2. So it's going to be PT0, TIS, T1, TA. And what you see is kind of what we've heard before and described before is variable response rates to neoadjuvant chemotherapy across subtypes, with luminal papillary having the highest downstaging. And so a hypothesis would be not to withhold neoadjuvant chemotherapy from this better risk patient population. So this is pathologic node metastasis with and without chemotherapy, suggesting that some of the subtypes are likely more resistant to neoadjuvant chemotherapy. That's not a novel observation. And then, so we've been thinking about how to bring this into the clinic for years. It's been kind of a pet project of mine, and working with Josh Meeks and Tom Flagg. This has been a trial design where you would take a subtype-directed therapy. The treatments are chosen based upon the expression patterns within each of the subtypes, and then compared to standard of care neoadjuvant chemotherapy. We're retooling this because neoadjuvant chemotherapy may be out the window. So there's new standards of care, and we're sorting out how best to approach this in the context of a randomized trial. There is a trial going on in the UK. Jim Cato is running the Gusto trial using a version of the TCGA classifier. I know he's enrolled to that. So it'll be exciting to see where that goes. And then just in conclusion, this is one of a number of translational medicine studies that we have planned for 1011. And it just shows you the value of the trial, even though this, I don't know, I don't see Chuck in the audience, this visual of elephants copulating is sort of still very disturbing to me, but it does take a long time. And then just some observations about the different subtypes and variable response to chemotherapy. So thank you very much. My email is at the bottom left. If you have questions or want further details, happy to respond to you. Thank you so much. Have a great rest of the meeting.